first site we are going to is Shanghai, and we warmly welcome our friend.
So it'd be our pleasure to introduce Amy Cai, who's from Shanghai, and she's going to be doing a live ESD. Hi, Amy. Can you hear us?
Hi, Mami.
Hi.
Can you see us? Yes.
We can hear you and we see you.
Good morning, Europe, and good morning, good afternoon, good evening to the world. And today we are very honored to take part in EOA for the 6th year. And today, the first opening case, we will give a basic diagnostic one. This patient is a semi-laryngectomy patient, after semi-laryngectomy patient, and he's on regular follow-up for OGD. Then we found a lesion here. Usually after hypopharyngeal cancer, we should look very carefully for those mucosal lesions in the esophagus, because it can be early esophagus cancer, multiple lesions, and this patient has come for this lesion. And we today with the magnifying scope we are using is Aohua AQ-300Z. I'm very proud to let you know that Aohua is a local-based in Shanghai company. When I was a resident, have the honor to do the clinical trial with the gastroscope and colonoscopy. At that time, that scope is still rigid. And today I'm so honored to have this chance to live demo their scopes. And you can see very clearly.
Welcome back. You also started already?
Yeah, a little bit. So I use the soft coag to do the marking so that the mark can be precise and sharp. And today I'm using a hybrid I-type, the first generation of the hybrid knife to do the dissection. And the generator we are using is file 3. So my preferred setting is Endoscopic AQ-300. It's more relevant to what we use in the past when we do 200D or 300D. So it's just personal preference.
Well, the science of current is still in the personal preference area.
The size of the lesion, you mean?
No, the science of you using which current is still under discussion worldwide.
Yeah. Yes. Everyone has their own settings, but as long as
Why
you
not?
are accustomed to what you are stick to, I think if the setting suits your habit, then it's a good setting.
Yeah. So Amy, we are watching you while you are dissecting. We understood everything.
Yeah. So after marking, I'm using a knife to dissect around the marking dot, which is the standard of ESD technique.
So you go around first and then you dissect?
Yes. So I'm doing a very traditional way of ESD for small lesions, but for large lesions, we need strategies to we build a bridge, we build a tunnel. But for small lesions, I just finish the circumferential cut, and then do the dissection around the. So using this knife, I can use. As you can see, I know that in Europe we already have the second generation of the Irving knife, but here we still use the first generation, and I like the first generation because I like the lens. But many of some colleagues in European countries, they think the older generation has a long tip, which they are not accustomed to.
And Amy, which scope is this that you have?
Yeah, I'm using our scope GT300T, which has a 210 degrees of the retroflex and 120 degrees of the down direction.
And what are the advantages of that scope? Was that your preference, or how did you select that?
For a therapeutic one, I would prefer 3.2 channel, as I said. But because for many of the, sometimes you have bleedings, you have a good suction.
Excellent. And earlier on, Amy, you were telling us that you found an unexpected lesion that you didn't see on initial inspection. Is that correct?
Yes. Because this patient referred to us with only this lesion, but I feel with the pre-examination we found three lesions that I already show on the magnifying scope. So diagnosis is very important for those patients.
Okay, sure.
Absolutely. I think we were talking when we lost feed that it's really important not to miss a lesion. And I was wondering, what do you want? This was presumably a case referred from you from another centre. What is the critical information that you want prior to planning any therapy?
Yeah, because if it's a post like esophagectomy, a post hypopharyngeal cancer patient, I think looking for multiple lesions between preclinical pre-ESD assessment is very important, because it's always like have a chance to have a multiple lesions in the esophagus.
Excellent.
And
Amy, I
likewise
think
for
Okay,
yeah.
sure.
I think we're going back and forth between Hamburg and Shanghai, and we also have Bronte Holt. Amy?
Yeah, Thomas.
Oh,
So
a lot of progress.
Quick work, Amy.
So with this knife, I'm doing a submucosal injection
Entschuldigung.
and then dissection at the same time. So it saves a lot of time. We can appreciate the blue submucosal layer very well. So for the first time, we are transmitting with 4K signals. So I don't know on your side, can you see the fibrotic tissues of the submucosal layer? I feel it's too clear to me. Because with daily work, we are not so used to 4K signals.
Für das Endoskop dann auch, oder?
Nee, vor allem tatsächlich, dass man nicht aus Versehen denkt, es ist drinne
Ach so,
und
verstehe.
losbrutzelt.
Verstehe.
You already dissected, right? Circumferentially.
Yes,
Distally, yeah.
yes, for sure. Here.
Yeah, okay.
So for the circumferential dissection is very important. When you go underneath the submucosa, you need to have a clear end. Otherwise, you will just surpassing the submucosal layer. So you have to do the distal end first.
Yeah, so what we call under tunneling.
Yeah, on the tunneling.
And you never stop.
Yeah. So after I almost done, I will see the distal end from my submucosal tunnel.
So do you then go from the sides?
Because this lesion is not that big, so I just go parallel. I mean, right and left. But yes, you are right. If you are planning a tunnel, you can go all the way to the distal end and see the mucosa side. Then you go left side to the lateral side. So, but this lesion is just not that big, so parallel dissection is okay.